everyone, and welcome to Uplift International's conversation on democracy, human rights, and the right to health in the time of COVID-19. I'm Beth Rivin, president of Uplift International, and I'm thrilled to be moderating our remarkable panel today. For almost 25 years, Uplift International has created solutions to improve health for all people, especially the most vulnerable. We believe that every individual has the right to health, and we build rights-based health programs, create human rights and bioethics training for health and legal professionals, and convene health conversations across sectors. Today, our conversation focuses on democracy, human rights, and the right to health during the COVID-19 pandemic. No doubt this topic is extremely broad and interdisciplinary, which is exciting and challenging at the same time. The linkages between democracy and human rights and the viral pandemic control are complex, bidirectional, or even multidirectional, and these are important for us to understand in our interconnected world, as it were. Remember, during the COVID-19 pandemic, no one is safe until everyone is safe. Viruses don't recognize international borders. A pandemic presents an unusual situation for us to consider and explore individual rights versus community rights, versus the role of the state in protecting individuals from a deadly disease. Different societies, different cultures, and different governments have addressed the situation very differently, and we will explore this during the next hour. Not only is it interesting to think about at this time, but these examples are valuable for pandemic planning in the future. Democratic principles are enshrined in human rights law, but when is it necessary to limit individual rights during a pandemic for the greater good, to save lives? What has been done in China and in India, and how does this compare to other countries, including, of course, the United States? What can be learned? How are the COVID-19 vaccines being distributed? And what is the rights-based approach for this in wealthy countries or in low and middle income countries, and for all populations within countries? What about vaccine diplomacy that both India and China have engaged in? So let's get started. I will introduce the speakers, and then they will give us opening comments for 5 to 6 minutes before we start the discussion format with questions and answers. If you have a question, please do enter the question into the Q&A box. We will try to get to as many questions as possible during the next hour or so. So our first speaker is Professor Benjamin Meier. Benjamin Meier is an associate professor of global health policy at the University of North Carolina at Chapel Hill. Dr. Meier's interdisciplinary research is at the intersection of global health, international law, and public policy. And he examines rights-based approaches to health. Dr. Meier works collaboratively across the University of North Carolina's Department of Public Policy and the Gilling School of Global Public Health, and has written over 90 articles on the development, evolution, and application of human rights in global health. He has written 2 books recently, Human Rights in Global Health, Rights-Based Governance in a Globalized World in 2018, and more recently than that, in 2020, Dr. Meier has published an academic textbook for the field of health and human rights, Foundations of Global Health and Human Rights. He's also recently launched a quarterly column on global health law in the journal Law, Medicine, and Ethics. Dr. Meier serves as a scholar at Georgetown's University O'Neill Institute for National and Global Health Law, and as founding chair of the American Public Health Association's Human Rights Forum, as the acting chair of the Global Health Law Consortium, and as a consultant to international organizations, national governments, and non-governmental organizations. Our second speaker is Dr. Amar Jesani. Amar Jesani is an independent researcher and teacher in bioethics and public health. He is a co-founder of the Forum for Medical Ethics Society and its journal, Indian Journal of Medical Ethics, which has been published since 1993. And since 2012, he has been the editor. He is a visiting faculty member at Ganapaya University in Mangalore, the Center for Biomedical Ethics and Culture in Karachi, and Kenya Medical Research Institute, or KEMRI, in Nairobi. He is a member of the research ethics committees at the Tata Institute of Social Sciences and Médecins Sans Frontières, or MSF. He has co-authored and co-edited 9 books, the last co-edited with Purendra Prasad, titled Equity and Access, Healthcare Studies in India. Our third speaker is Dr. Joan Kaufman. Dr. Kaufman, who is a member of Uplift International's board of directors, is the senior director for academic programs for the Schwarzman Scholars Program, a 1-year, fully funded fellowship based at Tsinghua University in Beijing, China, aimed at training future global leaders who can bridge China and the world. Joan is also a lecturer in global health and social medicine at Harvard Medical School and has been a Radcliffe Fellow at Harvard and a Soros Reproductive Health and Rights Fellow. Dr. Kaufman has focused her work on China for her entire career, with 15 years spent living in China and working for a number of different organizations, including the UN, the Ford Foundation, Columbia University, and the International AIDS Vaccine Initiative. She was director of Columbia University's Global Center for East Asia from 2012 to 2016, and associate professor of health policy and management at Columbia's Mailman School of Public Health. She founded and directed the AIDS Public Policy Project at Harvard's Kennedy School in 2002, and was also affiliated with Harvard's Hauser Center for Nonprofit Organization. At Brandeis University's Heller School for Social Policy and Management, she was a distinguished scientist, senior lecturer, and associate director of the master's program in health policy and management. She publishes and teaches on global health policy, HIV and AIDS, women's rights, reproductive rights, and reproductive health, emerging infectious diseases, and civil society with a focus on China. Welcome to all the speakers. Ben, will you please start our conversation with some comment?
Happy to do so. Reflecting on the ways in which the COVID-19 pandemic has in so many ways inflicted cataclysmic suffering throughout the world, with sweeping implications for human rights in global health. Grateful to Dr. Rivin for bringing us together. I hope to extend some of the thinking around the right to health in the context of the COVID-19 pandemic, helping to set up the exciting conversation that will follow with Amar and Joan. I hope to intersect my work in health and human rights, global health governance, and global health law to focus on the ways in which the right to health can provide a foundation for global governance in the COVID-19 response. When we talk about the right to health, we're talking about a right that is somewhat new, was declared for the first time in the 1946 Constitution of the World Health Organization, detailed for the first time in the 1948 Universal Declaration of Human Rights, and codified under international law for the first time in the 1966 International Covenant on Economic, Social, and Cultural Rights, establishing a right by which states are responsible for the prevention, treatment, and control of epidemic, endemic, occupational, and other diseases, but also for creating the conditions necessary for medical service and medical attention in the event of sickness. Helping us to frame a focus on equity and health, this right extends beyond medical care, embracing socioeconomic determinants of health and requiring governments to adopt legislative, administrative, budgetary, judicial, and other measures to implement their obligations. This right to health has now evolved under international law to provide a foundation for the COVID-19 response. And I hope to briefly discuss the implications of the right to health for public health prevention in the response, for healthcare services in responding to those who are ill, for social distancing measures, and finally for global solidarity in the global response, especially in ensuring universal and equitable distribution of the COVID-19 vaccine. Beginning with a focus on public health prevention. We recognize that states must take immediate and progressive steps under the right to health to prevent this clear public health threat. Protecting public health requires attention not just to the health of the entire population, but specific focus to the heightened risk of vulnerable and marginalized populations. As we saw in the early years of the AIDS response, it's marginalized and vulnerable groups who are bearing the disproportionate burden of COVID-19 infection, including migrants and displaced persons, those in criminal detention and other institutionalized settings, racial and ethnic minorities, older persons, and those with pre-existing conditions. In addition to that, we recognize those who are vulnerable by virtue of a failure of other basic human rights, whether those who lack housing, whether those who lack financial resources, whether those who lack access to reliable water, sanitation, and hygiene. And recognize the inherent dignity of all people, creating the conditions that are necessary to prevent this public health threat, and prioritizing the special needs of marginalized populations. We need to consider the obligations of the right to health as a foundation to deinstitutionalize wherever possible, to support social distancing measures, to provide contact tracing of infected individuals, and to assure that disease testing is available, accessible, and of sufficient quality to all who need it. Once we've dealt with prevention, we need to think about healthcare services for those who are infected, with the right to health raising an imperative to ensure appropriate COVID-specific healthcare. And yet this crisis has made clear that many healthcare systems are unable to withstand a prolonged health crisis, with pandemic preparedness undercut by years of budget cuts and austerity measures, with health centers lacking the basic resources to meet essential health needs, tracing those with the disease and treating those who present themselves. And as patients have overwhelmed health centers, the response has heightened government failures to ensure the availability and accessibility of necessary health care, leading to rationing of basic health services, shortages of personal protective equipment, leading to infections among healthcare workers and other frontline staff, and user fees that have left vulnerable individuals unable to afford necessary treatments. In thinking about social distancing measures, we recognize that international law does not prohibit all social distancing measures. It doesn't prohibit limitations on individual rights to protect the public's health. In fact, human rights law recognizes the specific need for suspending human rights in the context of a public health emergency, but seeks to constrain those limitations on rights and make sure that they're undertaken only when they are necessary and proportionate to the public health aim, where they're specifically prescribed by law, and when they're available as a last resort, using the least restrictive means available. During these rights limitations, especially during periods of social distancing, we need to consider not just the limitations on individual rights, but the ways in which governments are responsible for ensuring the human rights that underlie health during periods of social distancing, making sure that social distancing doesn't come at the expense of mental health care and social well-being, rights to food, housing, water, and sanitation. In the absence of these underlying determinants of health, orders to stay at home are really impoverishing communities, keeping individuals from purchasing basic necessities, closing off necessary support services, and widening health inequities. And finally, we recognize that this is a global public health crisis that calls for solidarity and international cooperation and assistance. And yet states have largely responded with nationalist approaches that ignore the collective need for facing this common threat together. Despite this imperative for collective action, governments have scrambled to establish nationalist responses to hoard vaccines and prospective vaccines. We need now a dramatic shift toward global solidarity and shared responsibility under human rights law, with the right to health recognizing international assistance and cooperation as an obligation on all states in a position to assist. Although the barriers to global health coordination and universal vaccine access are complex, we've developed a series of new global health governance institutions in the past year to support global solidarity in facing this common threat, reaching agreements now to help secure equitable access to this new vaccine. This is an unprecedented pandemic response that raises an imperative to reestablish universal commitments to the human right to health. And I think if we talk about the right to health, we should recognize not just its development under international law and not simply the rhetoric that we all deserve a right to health, but to think about how governments can implement this right to prevent, treat, and respond to this threat across nations, bringing the world together to ensure the highest attainable standard of health for all. Thank you.
Thank you, Dr. Meier, for that very good overview of human rights in this particular unprecedented pandemic and the overarching value of international human rights law in framing the, health, in framing obligations, in framing duties of governments for the people. So let's move on before we get to more conversation. And Dr. Jesani, Amar, please, your comments.
Hi, morning. This is very early in the morning in Mumbai.
Sorry, so sorry.
There is no problem because we also organize webinars here and call people from North America at a very odd hours. So that's not the issue. I think, as you said, that we need global solidarity, and I think we should be doing it. What I'm going to talk about, it's in the context of India, is that we may say that the webinar hits everybody, but it doesn't. I think that's where we need to recognize very well. I think the first time, perhaps in recent history, a pandemic has taken place where the effect is more on the rich countries than the poor countries. And when this started, I was trying to read all kind of material, the ethics guidelines related to pandemics or the human rights position and all. All of them were framed with the understanding from the West rather than us. Every time it was believed that the infectious disease is going to affect the poor people more and more. So very paternalistic. They'll say that, well, Ebola, where it is in the West Africa, very backward people. politically unstable. And now when it happens, a pandemic which affects the developed countries more than the underdeveloped countries, I think a lot of things get unsettled. And that's how I think, as a beginning of our reflection, we should interrogate a lot of things that we have laid down in the field of human rights and the public health, keeping in mind the learning from this pandemic. So that is my opening statement, and I say this simply because we may have to rewrite many of our international documents. That's what's my feeling. That keeping in mind that everybody can get affected. In India, we started. The first case was reported on 30th of January 2020. And the first reaction, organized reaction from the government, comes in the third week of March. In between, our Prime Minister hosted the President of USA in a massive public meeting, a show of solidarity. And then when it came on the head saying that they have to react, they gave 4 hours notice and clamped the lockdown in the entire country. 4 hours notice to do a lockdown in a country like India, more than 1 billion people, and 1/3 of them living below poverty line, and a large number of others having very unstable employment. So that's how it started, and now you'll find that as compared to most of the other countries, developed countries, we are in a much better space. But you can just imagine it's not just India. Look at the entire South Asia. Look at Pakistan, look at Nepal, look at Bangladesh, Sri Lanka. You will find that somehow the impact of pandemic has been much, much less as compared to what you are seeing in Europe and North America. Perhaps it is the composition of our population, or is it climate or whatever. But government did not come under that much of pressure of pandemic as they have come under in the developed countries. There were 2 major, learning for me from the response to the pandemic. First is that this public health is a very important issue. That how do you respond to a crisis like this? Is there a public health science which needs to be applied uniformly, irrespective of the context? I think that was the first learning that I got from. That lockdown was considered to be the best strategy by the developed country, and our Prime Minister borrowed it. Some of our public health experts borrowed it. There were many dissidents; they were not given, much hearing, but it was just taken up and imposed on India. Actually, the lockdown, both in India as well as in developed country, had a very adverse consequences. So lockdown does not mean that the entire society is locked down. All the essential functions of the society needs to be continued. And in your country, all those services which are provided as essential are manned by people who are migrant, who are poor, large number of them. And that way, lockdown is a protection of rich and exposure of the poor to the infection. And that's what happened in India. In India, it was worse simply because the context was never taken into consideration. We were so obsessed with a virus that we forgot that the people live in real social reality. We forgot that we had a huge number of internal migrants. You can talk about people coming from outside. We have within India huge number. I mean, there are poor regions from where people migrate in millions to the rich regions to work. And once you stop the economic activities, all of a sudden, without giving them anything, they starve. And when they starve, They start walking because there is no transport available. Massive internal migration, which we saw first time in the quantity as comparable to the partition of India in 1947. Massive, where the several million people almost walked back for thousands of kilometers, and many died. Dozens of them died in the process. And people who were starving, for them there was no no arrangement made. So when we talk about human rights and say, yeah, people's civil rights can be suspended, but suspended under what condition? What is the reciprocal responsibility of the state which suspends it? I think it's a very, very important issue to ask. That if you don't keep your promise of reciprocity, should you have a right to suspend the human rights of the people, or civil rights of the people? Should people have a right to protest against it and say that this is not the way? And should public health community accept this kind of strategies where the reciprocity is not maintained as a scientifically right thing to do in those contexts, or advocate? And you know that public health community internationally is splitted. There are people who are talking about doing less as a paternalistic approach, as compared to those who are saying that you have to be highly paternalistic in order to fight the infection. So I think the context decides quite a lot about how public health response needs to be articulated. And India is a classical example. Lockdown is not the only one, but the subsequent event, if you go into details of it, as the questions come, we'll be taking it up. But this is the first lesson that I have. And the second, and that is the last point that I want to make, is that it's about the healthcare services. People do get infected. Some of them require medical care in the hospitals. What I wondered, during this period was that while my right to go out of the house was suspended, the rights of the corporates running hospitals were never suspended. Why was the right to property given huge respect as compared to civil rights of individuals in the society? My government did not take over the healthcare services and said that you have obligation to provide healthcare to everybody, irrespective of whether they have money or not. Now, how can I have money when you have already taken away my employment? It's only those people who have surplus capital, surplus income, they will be able to shell it out. The rest of the people can't. So it seems that when we talk about human rights, there are certain rights which are never touched. The rights of the weakest are attacked first as a necessary response to the pandemic. Rights of the rich not. And after 1 year, if you look at what has happened to the economy, you will find that India added dozens of new billionaires in its list during this period, while millions have gone poorer as compared to what it was 1 year back. As you said, the disparities have increased, I agree. But it has increased because of our willful policies. Our human rights is extremely biased. It is biased against people who are poor, and it is in favor of people who are powerful and who control the means of production. I think that's where we need to make a distinction. It's not that human rights are not important, but they need to be looked at in a wider sense. The right to property is respected. You and I are not. And we are told that in order to save us, right, this is being done. I think this needs to be questioned. And that is my second, reflection, that why shouldn't we have taken over the hospital services from the private sector, which is the dominant one, even temporarily. I'm not saying that you take away permanently. I mean, we are not taking away civil rights of the people permanently. We are taking it temporarily. And why couldn't have that been made to work free of charge, without charging anything from people all the time, during the pandemic? But it was not done. On the contrary, government kept giving them contracts after contracts, did not even regulate the services in India. And they made huge amount of money rather than, getting into the loss while everybody else was in the loss. And this is the first time perhaps in India where even the middle class, which always supported neoliberal policies of keeping market as the main means of the working of the society, suffered. So I think these are the two major lessons that I learned from this pandemic, which has direct relationship to the democracy as well as human rights. And that's where we need to do more reflection. Thank you.
Thank you very much, Amar, for your provocative comments and opinions. I always welcome them and expect them actually from you, which is great. You are highlighting the rights of the weakest and the duties of the government to protect the most vulnerable, to protect every individual, not just the wealthy. The growing gaps between the rich and the poor during this pandemic and the lack of protections of the most vulnerable and the need to balance human rights. There are competing rights. They need to be balanced. And what does that balance mean during a pandemic? I think those are really important questions that you raise. So we will set them aside, some more discussion, and have Dr. Kaufman-Joan speak about these issues, in particular related to China.
Great. Well, thank you, Beth. And thank you, Amar and Ben, for your really great comments preceding mine. I do want to echo, the theme of, inequity. And I do think that this pandemic has really highlighted for all of us, what those of us who teach global public health, have been talking about or teach about, right? But it's really, I think, made the fault lines ever clearer about, the importance of the social determinants of health and the great inequities, in the world that have made this pandemic so much worse for some people than for others. But other themes as well. I mean, the lack of preparedness for the next big one, which everybody knew was coming, right? How could you not, take SARS, for example, as a warning sign, and the other types of pandemic flus, swine flu, avian flu. And as a global community, we really failed to really organize ourselves for the early, warning systems, lots of talk, not enough action. And also, I think it's also highlighted the very important issue of government accountability and trust in government, right? Whether the government is authoritarian or democratic, I think what we've seen in places like Taiwan, South Korea, and even in China, effective control of the epidemic has been very much driven by governments, putting in place the public health measures in New Zealand, places like that, the public health measures that are needed, and the citizenry trusting the government enough to actually, do it. Certainly in this country, we've seen the, that problem. And I do also want to highlight, that the needs for global cooperation are so important, including on climate change. The loss of habitat for animals, the close proximity of animals and people. We're going to see more and more pandemics, more jumping of animal viruses to people. So, we do need to get our act together. But, meanwhile, I did want to say a few words about China. And, it does give me pause to talk about human rights, democracy in China in the same phrase, right? But, on the other hand, if you look at, you take Ben's definition of health and human rights, China's done a pretty damn good job, I have to say. And, I think I do, at the risk of sounding like too much of a panda hugger, which I think I probably am, I do think it's important to give China credit for, after the early missteps, for really very effectively bringing the pandemic under control, including sharing the genome with the world, in early January, which is the basis of every vaccine effort in the world, right? Making that publicly available on the internet, set off this, incredible, development of creating not just one, but many, many vaccines over the course of record speed, right? So I do also have to say that after the early missteps, which were substantial, and China is where it all started, and perhaps earlier containment would have avoided a lot of what we see in the world today. I do think that China did get its act together, first by locking down Wuhan, which was an unprecedented move, locking down a city of 11 million just several weeks into the pandemic. And then, there was really no playbook for how you do this on a global scale. And then I think then putting in place, one could say draconian at the time, but I think we see in retrospect that those very measures of quarantine, social distancing, testing, control, contact tracing, what resulted in China now, after several really awful months, has been back to normal for, business as usual, really, very much within its boundaries for quite a few months now, and with very few cases. If you look at the scheme of things, China has had 5,000 deaths compared to our, 500 million in the United States, and the Chinese public very much support the government for having put in place, despite a lot of loss of liberty along the way, and many things that, I think might be unacceptable in other places. I think the citizenry is grateful that their economic recovery is underway, and it's back to normal, for most of the country. So, so let me just then just say that I think, China's done some really interesting things. I think China and the U.S. are both kind of science powerhouses, probably, and India as well, big powerhouses that have been able to really deploy science. In the case of China, AI in behalf of the sort of COVID response, and things like using, first of all, launching the contact tracing app, which is being used in many places in the world. And, dealing with the issues of privacy, I think, and trading off the privacy issues for the public health outcomes, right? It's a kind of a gray area, but nobody I know in China is really complaining about an invasion of privacy. They all have the WeChat or the other app on their phone, which, is red, yellow, and green, and lets them know in real time if they, are have been exposed to anybody who's tested positive. Also, they've tested an enormous amount of people and constantly testing, and have put in place the basic public health measures, I think, to keep the virus very, very contained within their own borders. Of course, what it means is that there's no herd immunity. And now that the vaccine effort has begun, China's really out there doing vaccine diplomacy. And that's another issue, I think, when we're looking at the issue of equity. It's really important to say that the inequity in vaccine distribution, with the North buying up so much of the vaccine supply, obviously the need in places like the United States is great, but it doesn't mean that, the developed world, should have, 5.8 of the total 8.2 billion doses of vaccines that have been manufactured. So you've got these facilities like COVAX that are committed to getting vaccine out to, the low and middle income countries. But China's out there. They've got, they've donated 500 million vaccine doses of their two vaccines they've developed, the Sinopharm and the Sinovac, to 40 countries. So they're really doing serious vaccine diplomacy, and it's contributing to the inequity gap. And I think it's important to note that, that's a positive global role. So I think I'll just stop there, and I'm sure we want to leave time for questions, and happy to answer any of them. So.
Thank you so much for your comments about social determinants of health, the lack of equity during the pandemic, and what's going on in China, which is fascinating, in contrast to India and in contrast to many countries around the world. I think, given the time, it seems that it would be best to open up comments between and among you all, and perhaps just Ben, you might go first to just respond to some of the comments, and if you would like to talk about the rise in populist nationalism and how that might be affecting the pandemic, how that is affecting and impacting democracy and human rights in general. A broad question, of course, I'm asking. And respond in any way to the comments that Amar and Joan have made as well.
Happy to begin the conversation. I'll try to stay brief in doing so, answering your question about populist nationalism, and then trying to draw out a theme that cuts across both the Chinese and Indian experience in preparing populations for extreme periods of social distancing, and the ways in which both rights and health were undermined by a failure to adequately prepare. When we think about populist nationalism and the rise of populist nationalism coming about just prior to the advent of the pandemic, we recognize that the governance principles that define populist nationalism were perfectly suited for a failed pandemic response. And we begin by focusing on the rejection of science among populist governments. That so much of the response to a pandemic depends upon an understanding of disease transmission, of social distancing measures, of taking the politics out of public health decision-making. And this rejection of science, this undermining of independent thought in the media, all come about at a perfect time to deny both transparency in the response and a reliance on public health practitioners in that response. Secondly, we think about populist nationalists in particular as really violating human rights as central to their populist nationalism. That we're seeing governments that are deliberately repressive, scapegoating marginalized groups, exploiting chaos in order to consolidate power, punishing those who dare to oppose government officials. And we see examples of this in both China and India. We see in the United States populist politicians who are willing to exploit xenophobia, racism, and divide the world in order to further their political ambitions. So we see a rejection of public health science. We see a violation of human rights. And then through nationalism, we see a subversion of global governance. And the idea that nationalism is spurring isolationism, with China withholding information from the World Health Organization at a time when it was needed most, with governments now engaging in vaccine nationalism rather than contributing to global efforts, with WHO essentially holding out its hat every day and screaming unity and global solidarity as much as it can. We see that populist nationalist governments are really undermining these three pillars of a pandemic response: the scientific pillar, the human rights pillar, and the global governance pillar. And I think returning to the question that I wanted to ask to my fellow panelists, and I regret that some of it is maybe because the responses in India and China were so early in the response that there weren't really good practices at the beginning to draw upon. But both countries attempted a vast, sweeping, unprecedented lockdown with little time. I understand that there was an imperative for speed, and yet there was very little consideration of the underlying social needs of people during these periods of extended quarantine, whether it was, as Amar says, people who were impoverished and forced to find their way home, walking for weeks at a time, or whether in China where a complete lockdown exposed people to inability to access medical care, mental health care, access to necessary food, water, basic sanitation, and that these, while these statistics aren't picked up in the pandemic response, there were lives lost and there was health diminished in this. And so how do we think about the role of human rights, not just the right to health, but the wider range of human rights that underlie social protections during these periods of lockdown?
Great.
I'm happy to say, I think with respect to China, we may never know really what happened in Wuhan in the early days of the epidemic. History is rewritten in China in favor of, the ruling party, and alternative versions of it are frequently, suppressed, right? So I don't think we will really know. But what I do think is that it was an unprecedented situation in the sense it was the early, the first site of the pandemic that exploded, especially after the early missteps. And the basic approach was, I think, really a kind of example of, I was at the Syracuse principle where the government can abrogate rights on behalf of a public health emergency. And I think the approach was entirely kind of organized from a public health science-based perspective about how to, get this epidemic under control and deal with the, I'm not making an excuse for it. I think there was huge personal, a million stories of rights violations and consequences, which we may never hear about. But I do think it was a sort of a unique and unprecedented situation. I'm not sure, what else to say about that. I think it was the early and first phase of a global, global pandemic.
Well, I think perhaps I'm turning too critical or self-critical of what happened in India. Perhaps it is because of the lived experience. When you talk about lockdown, most of the data that I have been seeing of other countries show that lockdown really slowed down infection, and you find that the curve really going down slowly. If you study Indian lockdown, it started on 24th of March, and for next 3 months, the graph kept going up till it reached the peak. How do you explain the effect of the lockdown, which is completely contrary to what was expected? Now, it is passed on as a saying that, well, if lockdown was not there, the graph would have gone much, much higher. We don't know. Nobody knows. It's a speculative thing. The point is that if you lock down the entire country and don't lock down only the regions where the infection is found, you are creating a situation where people have no means to survive. And people are going to rebel against your lockdown. And they did. Because they need to live. We should know that, say, out of 18 million people in Mumbai city alone, 9 million don't have house, which can be called house, where you can have little social distancing possible. It may be 10 by 10 feet hut, where 5 people may be staying. So what is social distance? Whom are you asking to keep social distance? They can't sit in the house for 24 hours in that hut. They have to sit on the passages outside. Now, this is the reality. If you don't know as a public health expert, then what is the science? Science is only germ that is you are worried about, that virus. I think that is not public health science, to my understanding. Virology, yes, good virology. But you have to look at it in that context. And I think where those people who said that your public health policy should be designed to the needs of the context are they were right throughout this thing. And that's what I find, that some attacks on the different kind of strategies, people that followed, like, say, the way Sweden has been criticized, not just criticized, but very badly criticized. But if they made mistake, no doubt. Everybody made mistake. India made mistake. China made mistake. Americans have made even more mistakes than others. Right? But there is so much of intolerance within the public health community that they are vicious attacks on each other, which I just cannot understand. We need to see that, yes, in each context, people have taken different measures. And within that, there are criticism. We are trying to correct it. And I think that criticism is very important, coming from Sweden as well as US. But there is no uniformity of one science of public health that we are talking about. Let me tell you, for decades, I'm 67 years old. Since I got into the medicine and public health, we have been fighting for some understanding, good political understanding in the public health, not getting politics out of the public health. Right-wing politics is bad, I understand, right? But not the good politics. There is no public health without politics. Public health is not just something called neutral science. Public health is like a politics, whether you are with the people who suffer or you are with the people who control the society. Whether we like it or not, there are distinctions of class and the power, which are more visible within the public health than anywhere. And that's how public criticism of public health or critique of public health is also the critique of the politics of that time. And if you have a politics in a country which is very authoritarian, it uses the public health crisis to become more authoritarian. And that's what's happening in India. That we have a regime which is which is not respecting the institutions of democracy. And during the public crisis, it actually undermines those institutions more. It depends upon the context. And in a better, more democratically governed society, if the pandemic happens, it is more sensitive to the needs of the people. It makes mistakes and it tries to correct. Everybody makes mistakes when completely new virus and new things come, and you have to keep learning. Every day you are learning, and every day you are refining your strategy, right? But those are more sensitive people as compared to the insensitive people that you may see in the context of China or America of that time. I don't know whether the new time is going to be better than that time, but definitely, that. The other issue is are people really rejecting science? That's where I would like to join issue with Ben. Or are the people becoming more distrustful of science? These two things are very, very different. Are we able to produce good evidences for what we are doing? And when we say that we have evidence, are we able to get data supporting evidence in the public domain? No. As I said, that the state's paternalism works very good for you and me, but not for those corporates who do research. How many of you have seen the raw data of all the vaccines that we are, saying that they are great? Yeah, of that guy, and they may be doing something good. And we are all using it, and I also will take it. I delayed it because I had COVID only a couple of months back. So I have some immunity there. But I'll be taking it. But still, I have just doubt. I partly distrust, simply because I don't know. I have to just believe what Moderna says or what J&J says and other people say. But there is no one who can, find out. We just don't know how the approval to the vaccines are given. It's a major problem. Making it transparent and democratic. Science make science democratic. It should be one of the motto of this pandemic, saying that if you want to resolve differences in science in a more scientific way, then you have to have an open discussion. It can't be some scientists control all the scientific information and then say, trust my science. And then even scientists themselves, those who are not having that information are not able to trust them. How do you expect people at large to trust them? Just by selling your idea through PR, public relation, advertisement and all, and some authoritarianism saying that, well, if you say that the vaccine is not good, then it is a misinformation. Or that there are people who died after vaccination and you did not do good investigation of it. And if we go to the press and the media and say that, well, there is not good investigation to find out whether these deaths are related to vaccine or not, and you put me in a prison, okay? Or you gag me. That makes good science? No. By being more transparent, it makes good science. Then and then we can have good conversation on the subject of science. But the science is getting controlled elsewhere, and that makes me very, very worried that this pandemic, instead of opening up this thing, is actually closing things. The democracy is getting more even limited within the science as compared to time before the pandemic. I think we need to fight against this.
Yeah. Thank you, Amar, for this question. One of the audience questions is about China. So perhaps Joan can answer this. The question relates to transparency of data, transparency of minority people's data. For instance, what are the screening, testing rates for minority peoples in China? How do we know that the data from China, especially from the western part, Xinjiang and other parts of the country are accurate? How do we know, how do we believe the data from China?
Well, I think you have to take Chinese data with a grain of salt, after all my many years of working there. But I think you do see, trends, and you can make, educated guesses from the large sort of, data, right? Like when I say there are 5,000, less than 5,000 deaths in China from COVID compared to our 500 million, maybe there are 10,000 deaths, and I think actually Wuhan just did a retrospective of, like we did in New York or something, of people who probably died of COVID that weren't, labeled as COVID at the time. But I think the order of magnitude is usually, reasonably accurate. When you're looking at basic public health statistics, it would be obvious if it wasn't. You would be seeing a lot more people dying, sick, hospitals full, and all that stuff. So I generally believe the COVID statistics. I honestly have no idea what the COVID control efforts are in China's southwest or in Xinjiang or any of the national minority areas. But what I do know about China from my years working there is there's strong government control, and when the Chinese Communist Party puts its will to something and there's a political mandate, it is just implemented down the chain for better or for worse, really. And I do think, you saw that with SARS, you've seen it with other types of, public health and other types of emergencies in China. My guess would be that, you have similar COVID policies throughout the country because of the accountability system through the, the party hierarchy. The data, I haven't seen disaggregated data for COVID in Xinjiang or Yunnan or any of the other places. I just see national data, probably like most other people. And, the government won't publish what it doesn't want others to know. And, but, I think in the realm of public health, that's in general in China, I would say, there's, it's tightly controlled information system in all ways, right? But I think we would know if there was something different than what seems the order of magnitude of COVID cases.
Shall I say something in context of India about data issue? I think this is true for India also, because we don't have this kind of data available. That doesn't mean that we don't have oppressed minorities. We have Muslims, we have lower caste people, we have tribal people, and they constitute a huge number, more than 1/3 of the population. And we don't know whether they died more or they got infected more during this pandemic. The absolute figures of infection as well as hospitalization and death are considered to be a massive underestimation in India, to the tune of something like 30 to 50 times less reported than otherwise. Because there are areas where there are no services of a kind, or there is no data capture system existing. We don't have even the reliable data on the births. We don't have a universal system to record births and deaths. Forget about the COVID itself. So you must understand that if state does not invest in this kind of basic public health measures of creating public health data system, I mean, this is over the years. This is not generally just about pandemic, but even earlier, all the time. You will never get good data, irrespective of whether good democratic government is there or bad democratic government is there. At the same time, we had issues like, say, some studies were carried out to find out seropositivity with the COVID in order to understand whether we have more people who were infected as compared to what is reported. And they found that it was very, very high. Seropositivity was much, much higher as compared to the number of infections were reported. It's to the tune of 30 to 35 times more. But part of this data was suppressed, even from the medical journal, where some of the authors rebelled and came in the press and said that, well, part of the data were kept aside by the government because the journal is controlled by the government. I wrote an editorial in Indian Journal of Medical Ethics on that. And that is simply because they didn't want to see the underreporting of the data. So sometimes what happens that if you don't, like say, minorities and all are not reported simply because you don't collect the data. So it's not just the political system, but it is also a political decision that you don't want to show what is happening at the ground level. I think that's the major problem, and how to solve it, I think, is a big challenge for the public health community. They have to influence political leadership to change this and say that, well, good data is always will help you in having a better strategies and policies than the bad data that you have.
Right. So thanks, Amar, for that. Ben, you have your hand raised.
I think thinking about these two national experiences, how can human rights help us thread this needle? We recognize that there's a human rights obligation to collect data in order to respond to public health emergencies, but not collect too much data where we start to see the rise of a surveillance state in China. How do we think about balancing privacy protections against public health imperatives in the context of an emergency? And earlier, Joan raised the idea of the Syracuse principles. And this was this idea coming from the human rights tradition that we limit individual rights when necessary to respond to an emergency, where necessary, proportional, and focused on the science in legitimate and non-discriminatory ways. And so one of the largest concerns about the lack of transparency in China is the fear that the surveillance tools being used in the pandemic response will be used well beyond the pandemic response and will be used for autocratic control. And how can we think about the ways in which we can have time-limited surveillance with appropriate transparency and accountability of government officials with participation of minority communities in order to ensure that surveillance tools can be used responsibly in order to respond to a pandemic, but not beyond that specific mandate. And I think human rights provides us with tools that we can begin to think about using when we consider surveillance technologies.
I would say one of the problems, of course, is that I think we don't have the global governance mechanisms to make all countries accountable. The issue of sovereignty, I think, really trumps everything. I hate to use that word, in the sense that some countries, defend their right to govern within their borders and not have to abide by a set of universal rules that in some cases they weren't part of the creation of. So I think it's a challenge for us. How do we create the global governance mechanisms in the agreement that to do precisely what you just said, Ben?
So I realize we're over time. If you will, I'd like to ask one final question about vaccine diplomacy. And I'd like, in particular, Joan to respond about China, Amar to respond about India. India, of course, is one of the largest pharmaceutical manufacturers in the world, and they, India has been providing free vaccine, millions of doses actually, and they haven't vaccinated their own population. So I just like to spend a few minutes on that. It's important. And then if Ben could just talk about the solidarity of COVAX and how, that movement of working together, although it's not working as well as we want it to, how that is so necessary for everyone to really get vaccine, because no one is safe unless we all are safe. And so let's see. Ben, do you want to start on that and then have Amar speak and Joan speak, and then we'll wrap this up?
Sure. So when I spoke at the beginning, I spoke about obligations of international assistance and cooperation. And this is something that the COVAX facility seeks to realize, bringing the world together in order to ensure universal and equitable access to COVID-19 vaccines. Beyond the COVAX facility, we need to think about the extent to which there is not adequate capacity for creating vaccines in the global south. We need to think about not just capacity, but patents and flexibilities under the TRIPS agreement that can allow for some of the intellectual property to be shared among countries. A lot of the debates around human rights in access to a COVID-19 vaccine are framed based upon the original fights for access to HIV treatments in the 1990s, where advocates rallied in the streets, in national courts, in global governance settings to draw on the attributes of the right to health, and in order to make sure that access to medicines were available in sufficient quantities, accessible financially and informationally, acceptable to people throughout the world, and of sufficient quality. And so in focusing on these issues, COVAX can provide some of that availability, but not all of it. Patent debates can begin to think about some of the financial accessibility issues in order to lower the costs. And we need increasing national regulation, whether through improvements in national approval processes or through national immunization NITAGs, national immunization technology groups, I think, national groups that can coordinate with each other in order to approve vaccines so that we can make sure that the vaccines that are imported into countries are of sufficient quality. And so we can look to human rights in order to think about the ways in which we can strengthen global governance in order to realize this global solidarity. This is a complex issue. It will involve a number of different solutions, but right now, going back to the question of populist nationalism, nationalist actions that seek to undermine global governance and hoard vaccines for national populations both set back the eventual response to the pandemic and deny human rights to people throughout the world.
Thanks, Ben. Thank you so much. Amar?
Well, what to say? I said that the way global governance is around for a long time, it does talk about solidarity, but it has more or less, I think, denied the human rights to the people, right to healthcare. I think we need to see that who controls all those, patents. Who is having them? I mean, you can talk about India, you can talk about China, but they don't control all the patents of the big vaccines that we are talking about. Control is somewhere else. So role of global north needs to be brought in. I know we can pity the global south for being poor, but I think we have to, look at this part. How are you going to, force this big corporates who own these patents, or their democratic rights are not to be touched during pandemic, perhaps. This is what I was talking about earlier. Right? Everything else can be touched. So is it really important? I mean, that for those governments to do it. So that is first thing. Second thing is a country like India is called a pharmacy of the world because we provide huge amount of generic medicine throughout the world, and including, the developed world. I don't know whether America's, welfare, healthcare support, will sustain if generic drugs disappear from the market, right? So, it's very, very important that they are there. And throughout, when everybody was benefiting from India's pharmacy, nobody asked the question that are Indian people really getting drugs which are being exported out? No, we were not getting. Data show that almost 50% of Indians don't have access to basic drugs. So for us more. I'm talking about essential drugs. I'm not talking about the drugs in the tertiary care. This is the reality that we have lived with. And this is part of the global trade. And again, within that, every American president who came to India always brought representatives of the pharmaceutical corporates. And they always tried to undermine the generic industry in India, saying that, well, they are creating a competition against the branded medicine. Right? They never allowed a country like India to say exercise its right to compulsory licensing when an essential drug is required, in the public health emergency, HIV or whatever. Right? And if it did surreptitiously, then they were penalized. So you do something for this saving of people, say in healthcare, they will try to catch your neck in something else, because there is all the countries in the south are dependent on various kind of stuff, different technologies, right, that they import from the west, and suddenly everything will come to standstill. So this is an unequal relationship which exists, and I think it is manifested in vaccines too, right? And they play some diplomacy. Each one is playing diplomacy there. I don't like what India is doing. India needs to provide it to the people of the country. But it is also playing the same game, and that is not just nationalism, it is also business. It is capitalism too, that we need to recognize behind it. That Indian companies are looking for money. Only yesterday the data came that how many Indian pharmaceuticals, new companies, which were small one before pandemic started, have become huge one during pandemic. That is simply because they made big money during the pandemic. So this is happening, and they are exporting. The last thing is that no, India is not. They started with providing vaccine free of charge to everybody, but it was only everybody were restricted to certain groups, health workers, frontline workers, and all, and in the government services, if it is delivered by the government. And government services is only about 1/4 of the total healthcare services in India. The private sector is massive. And now they have started providing vaccine in the private sector where you have to pay. That means elderly people, people who are above 50 years and with comorbidities can go there in the private sector and get it, but they have to make a payment of 250 rupees at the moment, which is a small number. But that's how it started in the COVID treatment also, that initially you start with a small number, and after some time it becomes a big number. So the price will keep increasing as the private sector is able to put more pressure on the government, saying that, well, the delivery charges, the administration charges must be increased. That's how they did when their beds were used for the COVID patient. So this is they have opened it up to the market also, which I think most of the developed countries have not done it, that giving it to the private sector in this manner. But this is happening now, that at the point of service, if I go to any private facility to get vaccine, I need to pay money. And once I get used to it, perhaps they'll say, pay more money because you came late, perhaps, So this is a whole conundrum. I mean, it's not just about one nationalism and all, but I think it is a strong commitment of the international leadership to market market is non-viable under any circumstances, whatever may be happening, a pandemic or no pandemic. And that worries me because that ideology is not shaken by this pandemic. And we need to work more as a human rights activist to shake people's faith and faith of the government from this all-encompassing triumphalism of markets. That market is the only way out to fight the pandemic.
Thank you, Amar, for those comments. Joan, and then we have to end the meeting, our webinar soon, since we're so over time, but we have such an interesting discussion. I hate to stop it too soon. Joan.
Yeah, so I'll just be brief because I know we are really over time, but I did address the issue of vaccine diplomacy in my comments earlier, but, I do want to echo Jesani's comments as well that, for China's, they're doing a lot of vaccine diplomacy out there, donating 500 million doses, but the coverage within China itself is minuscule, really. They've vaccinated about 31 million people out of a population of 1.4 billion, and are giving away much more. They won't have enough supply for themselves. So, it's about the geopolitics. It's about the visibility of trying to address the South-South gap, the North-South gap in vaccine equity, being the good global citizen, being a member of COVAX, not withdrawing from the WHO. It's about China's, visibility globally as a champion of the global South. And I think, ultimately at the expense potentially of its own population. So I do think, we could talk forever about the patent system, the fact that pharmaceuticals, which are a basic public good, are controlled by private pharmaceutical companies. The arguments back and forth, is that good, is that bad? But ultimately, when we do come to things like the pandemic, the need for vaccines, the need for low-cost drugs, ultimately the WTO and the rules, the TRIPS agreement, they're not going to solve the problem. Ultimately, they're alliances of the North, the rich in the North with the rich in the South, the private businesses and capitalism, as you say. This is controlling a basic product that is an essential ingredient of good public health. So, but that's not the discussion tonight, and I'm not going to go there. I think it's a complicated issue. China is the ultimate market economy these days, and is the major producer of many of the active pharmaceutical, the primary ingredients for the global pharmaceutical industry. So, they're not going to invoke those principles either, because it will be at the expense of their own manufacturing industry. So it's a complicated global scene, interwoven, and not necessarily always good for health, and definitely not good for health for the poor. So maybe I can just end my comments there and say I agree with both of you, everything you've said.
Well, thank you so much, Joan, and thank you all for a very stimulating conversation about these very broad topics of democracy, human rights, the right to health. In particular, we even got to access to medicines, which is really a part of the right to health, of course, and COVID-19.